Can anyone hear me?
We can hear you.
All right, that's what I need to know.
Is that Cliff?
Yeah, who's that, Jeff?
Welcome on board. We're about ready to start. Katie, should we go? So for all of those attending our now 10-month delayed second session of the 2020 instructional course for the Lumbar Spine Research Society, would like to invite you to the second session. My name is Jeffrey Coe. I'm an orthopedic spine surgeon at Ortho NorCal in the San Francisco Bay Area in California, along with the co-chair Jason Savage for this past year. We've assembled an outstanding faculty for this second session of the instructional course. We have Dominic Pelle speaking on the understanding the radiographic parameters and alignment objectives in adult spinal deformity. Mike Dobbs from the University of Nevada will speak on preoperative planning, when, why, and how. And then Cliff Tribune will discuss achieving a solid arthrodesis at L5S1, the role of interbody fusion and pelvic fixation. And Daryl Brodkey from the University of Utah will speak about proximal junctional kyphosis and failure prevention and management. And Wellington Chu will speak to us about the appropriate use of biologics in adult spinal deformity. I've asked the speakers to try to stay on time so we can have a little bit of time from discussion that we missed after the first session. And but I still want to make sure that everybody gets a chance to listen to and view these fantastic lectures. So without further ado, introduce Dominic Pelle from the Cleveland Clinic. Dominic.
Hey, good evening, everybody. Let me just go ahead and share my screen here. Can everybody see the presentation?
Yes.
Okay.
We got it.
All right. Okay. So I'm Dom Pelle from Cleveland Clinic and talking about the radiographic measurements of adult spinal deformity. Special thank you to LSRS and the team and Dr. Jason Savage. So no relevant financial issues here. So beginning the talk, you know, the population is aging, and it's no secret that as they age, it's not insignificant proportion of them will develop adult spinal deformity, and so we're going to probably continue as deformity surgeons to get busier and busier as time goes on. So it's important to sort of understand spinal deformity of any spine surgeon, whether you're a deformity surgeon or not, and evaluate these patients and understand the differences between, you know, this patient who has a little bit of a different curve than this one here. And really it's incumbent upon us to understand what drives their pain and disability and what are the alignment goals of surgery. And to do so, we really have to understand radiographically, how do we measure that? How do we understand if they're in balance or if they're out of balance radiographically? And that's sort of the point of this talk. And so that any deformity talk should sort of mention Dubusset's cone of economy. And so within that balance, within that cone, your muscle expenditure is quite low. And then once you start to get postural issues and you fall out of that cone of economy, your muscle expenditure goes up, and then this drives some of the pain and disability. And so how do we radiographically determine patients that are within that favorable ergonomic position and patients that are not within it? And so we need to understand normal and we need to understand abnormal. And so when we think about global spinal alignment, regional spinal alignment, and spinal pelvic balance, we can split it up in that way. And so regional spinal alignment is the thoracic spine, the lumbar spine, the cervical spine, what's their kyphosis, lordosis, coronal issues there, and that's how we think about that. Global spinal alignment is more often what we talk about when we talk about deformity, and that's generally, or classically, I should say, measured by the C7 plumb line. So that is a line drawn from the centroid to C7 and straight downwards, and we measure how far that goes from the posterior superior corner of the S1 ventral or S1 end plate, the back of the end plate. Also, in terms of global spinal alignment, perhaps maybe more importantly, to consider the whole spine, including the cervical spine, we look at the center of gravity line, which is from the external auditory meatus, and we drop that down, and that should intersect the center of the femoral heads, and we measure that in relation to the center of the femoral heads. We'll spend a lot of time talking about spinal pelvic alignment today. And so when we think about spinal pelvic alignment, we think about three main parameters. One of those is sacral slope. So that's a horizontal line as it compares to the line of the sacral end plate and the angle that that's formed. The pelvic tilt, which is a line from the center of the S1 sacral end plate to the femoral heads and then straight north, and the angle that is formed there. And then the pelvic incidence, which is the angle formed between the a perpendicular line to the center of the sacral end plate and the femoral heads. And the pelvic incidence really is the geometric summation of the pelvic tilt and the sacral slope, as you can see here. And it's important to note that the pelvic incidence is a fixed parameter. Once you reach sort of adulthood, it may change a little bit as you're growing through adolescence, but once you reach adulthood, that should not change, and it's a fixed parameter that is special to you. And so, you know, one thing that we need to do is find out, well, what is normal radiographically for these patients, and we can't define abnormal without defining normal. And so a lot of studies have gone into this over the years in the last few decades. And basically it boils down to at least what we train the residents and fellows from a generalization standpoint, lumbar lordosis around 60 degrees, pelvic incidence is around 52, and then pelvic tilt is around 12 degrees. And what we're sort of aiming for in terms of achieving spinal pelvic harmony would be a match between your pelvic incidence and your lumbar lordosis within about 9 degrees. Why is that important? Well, as you start to get a mismatch and you have sagittal imbalance, or you're leaning forward, your global spinal alignment is positive, it's demonstrated quite nicely that this is really the main driver of disability. And this is a Glassman article, kind of classic article from 2005, comparing ODIs and SF12s to positive sagittal balance. And you can see quite a nice correlation there. And many studies have gone on looking at spinal pelvic disharmony and the functional detriment that patients suffer from forward positive sagittal balance. But patients can be tricky at times, and oftentimes they'll hide their deformity. And this is one of my favorite pictorial representations of that. So if you look at all three panes of this picture, the thoracic kyphosis, lumbar lordosis is the same, but the spine goes on to become balanced. And they do that by retroverting their pelvis. So you can see that the pelvic incidence may remain the same, but they decrease their sacral slope and they push their femoral heads way out in front of them, and they change their pelvic tilt. And so what patients do is they'll really increase their pelvic tilt in an effort to sort of bring that spine back over itself and become more balanced within that cone of economy. And so we have to pay a lot of attention to our spinal pelvic parameters, and specifically our pelvic tilt, to understand when patients are hiding their deformities. And so if we look at that in terms of outcome measures, you can see quite nicely that as you increase your pelvic tilt, your outcome measures decrease, and you have more functional deficit from that. So overall, when we're talking about spinal pelvic harmony, we want our SVA to be within 5 centimeters. So our C7 plumb line should be within 5 centimeters, our sacrum. Our pelvic tilt should be less than 20 degrees, and the lumbar lordosis and pelvic incidence within plus or minus 9 degrees. And we have a classification scheme for that. This is the classic Schwab classification scheme, where we look at coronal curve types, which we pay a little bit less attention to in an adult spinal deformity, and really kind of focus on these sagittal modifiers and spinal pelvic harmony, and matching our lumbar lordosis to our pelvic incidence. There's a lot of angles that have come up over the last decade in the literature, and in preparing for this talk, I sort of familiarized myself with things I didn't even know existed. And so, but one of those that I think is rather important is the T1 pelvic angle. It takes into account both your pelvic tilt or your pelvic retroversion and your overall spinal alignment. So that's a line drop down from the centroid of T1 to the femoral heads, and measuring that angle out through the line through the sacral end plate. And obviously, if you're really increasing your pelvic tilt and you still have a forward positive sagittal balance, this angle takes into account both of those factors. And it is correlated with ODI scores and SF12 scores throughout the literature, further validating this measure. And so over 20 degrees is generally what we associate with poor functional outcome. So global spinal alignment, there's a few different ways to measure this. I think this is quite interesting because it looks at the entire body. And classically, we thought patients would flex their hip and flex their knees before we quite understood that what they really do is retrovert their pelvis. But if you have the ability at your institution to take x-rays of the full skeleton and you can measure down to the knees, you can see that there's a large difference between these two patients, with the one on the right-hand side demonstrating positive sagittal balance, and then the one on the other side having kind of a straight global sagittal alignment. And so taking this all into account, these are our parameters, SVA, PT, and lumbar lordosis, pelvic incidence, and TPA. It's important to remember, I'm going to speed up just a little bit here to stay on time, that life is a kyphosing event. And these parameters should attempt to be rigorously met, maybe for the younger patients. But as we get older, before patients start developing disability, they can tolerate higher pelvic tilts, higher mismatches, and SVAs. And so perhaps we should sort of, in the elderly population, not focus as rigorously as overcorrecting these patients with the notion that perhaps we will propagate mechanical failure. And so sort of a generalized way we think about this is SVA less than 8, PT less than 25, and lumbar lordosis pelvic incidence within 15 degrees in the elderly population. And just a few words quickly on kind of what's on the horizon. I thought the GAP score was quite interesting. It's probably good to talk about here. So the GAP score looks at these 5 parameters: the pelvic version, lumbar lordosis, lumbar distribution index, and the pelvic alignment, and age. And so what they said basically when they were deriving this sort of scoring schemata is that what you should have as a person is dependent upon your pelvic incidence. So the GAP score is kind of like this continuum of what the lumbar lordosis should be, what the sacral slope should be, based upon each individual person's pelvic incidence. And so a quick way to calculate that out is if you look at what they call pelvic version, they look at your measured sacral slope, which is your ideal sacral minus your ideal sacral slope. And the ideal sacral slope is a mathematical factor based on pelvic incidence. So they looked at all these normal subjects and did a linear regression model to say, okay, in a person with a pelvic incidence of this, their sacral slope should be that, their lumbar lordosis should be X. And then, so they look at that in relation to their pelvic incidence. And then the lumbar distribution index is the lumbar lordosis at L4, L5 as compared to their overall lumbar lordosis. And if you calculate that all out, this sort of looks like the T-lix a little bit. What is their lordosis based on what they should be for their pelvic incidence? What is their pelvic version based on what it should be for their pelvic incidence? So you get these scores. And based on what your score is, you have a higher incidence of mechanical failure after adult spinal deformity. And so finally, kind of burgeoning on the horizon for all sort of orthopedic surgery and spine surgery is computer learning and AI, artificial intelligence. And that's kind of what I think is going to be on the horizon for understanding patients with adult spinal deformity. So if you sort of feel like this in looking at these patients, just remember that these are complex problems and these radiographic parameters are more of a guideline. You should take into account patient's age and other factors. Thank you very much.
Thank you, Dom. That was an excellent presentation. Before I introduce our next speaker, I want to remind the audience that there's a Q&A function within the Zoom for you to add your questions. Please use that rather than the chat function, and we'll handle the questions at the end. So our next speaker is Mike Dobbs, who's going to talk about preoperative planning, when, why, and how. Mike?
Yeah, thanks. Let me get my, sorry. Thanks a lot, and I want to thank Jason for inviting me. I think that was a great talk to flow right into my talk. Thanks, Dominique. Here's my disclosures. So I think when we talk about preoperative planning, we really have to get back to what
we're not seeing your slides, Mike.
Okay.
You need to share your screen.
How about now?
Yep.
Okay, good, thanks. So getting back to the goals of deformity surgery, we have all these different measurements that we have, and we have to consider those along with the patients. So but I think it's good to always really get back to the basics of what we're trying to do with all these really complex surgeries. So really I always teach the residents that first of all, we're really trying to treat what's the underlying disease. A lot of times it's more than just axial pain. It's stenosis, it's neurogenic claudication. So that's our first plan for treatment. And then we want to halt the progression of the deformity. So we want to make sure we decompress whatever levels are stenotic. And then if we need to instrument them or fuse them. A lot of times we don't, if they're less than 30 degrees and stable. We want to maintain balance, as we just talked about. That's the most important thing that we do, and we don't want to make it worse. And we want to allow for efficient, less painful, upright posture and ambulation. So, and then really the final thing is we really want to show or improve functional outcomes. If we're not doing that, then we really have a problem with what we're trying to do. So again, I love using this because I think this brings it down to the basics, what we're trying to do with these patients in deformity. It doesn't have to be perfect, but if we get in that cone of efficiency or economy, we're going to improve their ability to move and function and ambulate. I just want to show you, so this patient of mine, and just to show you how much disability these patients have when they're severely deformed. This is not efficient, obviously, right? This takes so much energy for her to just walk 10 or 15 feet. So this is what we're trying to improve, and I'll get back to her. So how do I look at my pre-op assessment? I think, again, I take as much time looking at the patient as I do the radiographs. It has to be holistic, not just radiographic. You have to know their age, how healthy they are, what are their needs. If they never move around, they've never been out of the house for 15 years, you probably may not really help their function by doing a huge surgery that's very risky. You got to understand their mental health and what are their expectations and what are their ability to tolerate the complications that may happen with this type of surgery. So I always use this. I've been using this for years. I used it at Utah because I think it's really important. The biopsychosocial model looks at the patient, not just the physiology. And this is what we all want to look at. We want to look at the x-rays and all our different measures and the gap score. But the psychology and the social environment that these patients are in is just as important to how they'll do, especially with these major surgeries that we do more than anything. And really, what's the reason? Because all those things affect our outcomes. That's why we have to really look at this holistically. And from a society standpoint, these are very expensive, high rates of complication, high revision rates. And if you're talking about total risk contracts for spine surgeons or any big organization, they consume huge resources and they're very risky. And the complications are very large. If you look at this, this is a combination of systemic analysis of all those different studies that a lot of us on this call or this conference have talked about. And it's really like a 30% plus complication rates, and major complications as high as 10, 11%. So it's really, we have to weigh all that with our patients. So the pre-op analysis is really a key. And if you have a spine team, Dr. Savage talked about this last week. This is the ideal if you can do this, but not everybody has this. If you can combine all these different people that are involved with the care before you render surgery, I think this really significantly improves the outcomes. These patients go on, even if they've made the first cut with all the people looking at them, they have all these education classes, pain service, and they've really shown that they've decreased the number of complications, readmissions, and all the things that we're being graded on. So I think that's probably the best way. This is the take-home picture, and this is, I'm reviewing this from what Dr. Savage talked about. You don't need that big Seattle group if you don't need to. If you look at these and you really try to stick to these when you're looking at your patients, and each one of these will keep you out of trouble, keep you out of infection rates, failure of implants. Opioids will give you less, if you decrease that, less chance of failure overall, depression. So these are things you really need to look at. Opioid use is a great paper looking at that, a systemic review if you're interested in that. And then again, that whole Seattle experience showed, it's interesting, only 17% of patients had what they considered a combination of realistic expectations and a good support plan, as well as stable mental illness when they were looking at all these patients. So that says a lot. So this is probably not the best patient to take on for a major deformity surgery. So so then I go to, once the patient's passed all that for me, as far as my pre-op planning, then I go to radiographic and surgical. And Dominique has given a great lecture on what that is. There's all types of different ones. I have to tell you, I'm still old school. I really still am looking primarily at pelvic tilt. pelvic incidence, and then lumbar lordosis, really to look at their overall alignment, as long also with their global sagittal balance. That's how I look at it. And then I do think the gap score is something very interesting to look at. It includes all these different parameters. I think it's something that we may be using. There's calculators for that. It includes a lordosis distribution index, and the results have been a little bit mixed on that. I know Dr. Brocchi, our next one of our later speakers, has their group didn't find that really correlated with outcomes. This is really what I look at with age related. So I really look at this type of classification. I look at the PI minus LL when I'm looking at my global plan for this procedure in the patient, looking at age adjusted though. There's been several studies as was shown. Obviously the pelvic tilt increases normally with age as well, and you got to take that into consideration. Surgical planning, I know some people use Surgimap. I know it's been bought by other companies. I think that there's a lot of different software planning that will help you with those surgical or radiographic thresholds. You can look at all this. They also include universal thresholds, the original ones, as long also with the patient-specific or age-specific alignment. So these are things that are built into the system. I think that can be very helpful. Again, I'm more of an old school guy. I don't really use these as much as other people. Some of my partners do use this. So I think these are something you should consider using. I think especially as you start out, it gives you the tools to also just think through these things as you're thinking through your various types of treatment you may give the patient. So once I've considered the patient and I've considered the radiographs, now I talk about the surgical considerations. So what are you going to do? Most of these patients that are older need decompression of some type. What levels am I going to do? Am I going to do an osteotomy? What am I going to do? Any of the inner bodies are the same to me. Am I going to do a Smith-Peterson pedicle subtraction, VCR? Knowing that all these have increased as we go up, the level of intensity have increased complications. Here's a patient, just show you real quick how I deal with this. One of my patients from a few years ago had previous surgery. She's rigid in the lumbar spine, unfortunately had distractive types of devices placed close to the thoracolumbar region, has very large SVA, and had previous surgery. Also, you can see the pain pump present. And again, what do I look at? I look at the tilt, I look at the pelvic incidence, and the lumbar lordosis. So basically what I look at on this, I try to keep it simple. I know this lady's really sagittally imbalanced, going to need a large surgery. She's going to need probably a larger osteotomy type procedure. So she's passed all the obstacles for me. She's in good health overall. Deformity is rigid. She needs large correction. What am I going to do? Then I go to the osteotomies. And this is what I use, the Schwab osteotomy classification. So at first I'm going to try to do, if it's stage 2, which would be a Ponte osteotomy, and then I would try to consider something more. On her, she's rigid. I'm going to need to do something more. So I'm thinking really sort of type 4 osteotomy. We know we can probably, with all the osteotomies, I think with A-lifts and O-lifts, we can actually get even more with the more wedge or lordotic implants that we can use. And we're all aware of the different osteotomies that are potentially possible. So I chose a type 4 osteotomy in her. Is she perfect? No, but we're able to really regain a lot of the lordosis and I think improve her overall zone of efficiency. You can see her pelvic tilt in these x-rays, how much it's improved with her correction and osteotomies that we've done. So you can see overall, it's not perfect, especially in the sagittal plane. I think she still has she's about 9 centimeters out on her total global alignment, which is not perfect. But again, I think she's in that cone of efficiency, which I think significantly helps her overall improvement. She's very grateful. And again, no PJF, because I didn't overcorrect her. I think that's one of the big keys. So I want to just show this case. This is that lady I showed previously. Went through I saw her about a year before I operated on her. She had heavy narcotic use. I told her she needed to cut down on that. She was also malnourished a little bit as well. And I told her she needed to consider that as well. This is her playing radiographs. You can see how far off she is. This is the lady I showed you before, how hard it was for her to ambulate. So I know that I'm going to need to do a significant correction on her. However, she needed to go through all the things I've recommended for her. It took a year for her to come back. I talked to her. She'd come back every 3 or 4 months. She finally came back. She didn't smoke. She cut her opioids down by about 75%, put on weight. And I felt at this point, she was a much better patient overall to get a decent result. So then in my surgical planning, my plan for her, because she's never had surgery, I do a cheap man's radiograph, plain radiograph. I check the MRI films to see how much she improves on the table. So just have them lay on the table in the office and see how they look. A lot of these patients that have deformities like her can improve with time. My plan is to do osteotomies, just do Pontes or a stage 2 type osteotomy, but prepared to do one that's more advanced. And that's what we did. We're going to do a multiple Ponte osteotomies or Schwab 2s to get her correction. And we're able to get a nice correction on her. And I just want to show this because this is why we do what we do. This is why we try to get in the cognitive deficient. This is her at 1 year post-op. There's such a difference here, and this is why we do what we do. However, if I jumped in on her earlier and she didn't have support, was on all the opioids, I can tell you that our results would be a lot worse. So again, I think you have to look at patient factors most importantly, then think about the radiographs. Make sure the goals are age specific. Remember the cognitive efficiency. I think that's really important. It doesn't have to be perfect. Remember this about deformity surgery. It's a humbling business. So thank you very much.
Thanks, Mike. Excellent presentation. Fantastic result in that patient. Again, to the participants, please submit your questions via Q&A. We'll submit them to the panel at the end. Next, I want to introduce Cliff Tribune, who's going to tell us the role of interbody fusion and pelvic fixation. Thanks, Cliff.
Thank you, Jeff. I'd like to thank both you and Jason for letting me participate tonight. Trying to share my screen. I'm hoping this is going to work here.
Yep, but you got it.
All right, beautiful. Okay. All right, so my role here today is to talk to you about achieving a solid orthodesis at L5S1, what's the role of interbody and what's the role of pelvic fixation? These are my disclosures. So the first question really is why fuse L5S1? There are a lot of conditions that involve L5S1 directly, which I'll talk briefly about, but spinal imbalance and the things that we've been talking about thus far with Dominic and Mike are really with the crux of what this talk is going to be. So what's hidden in that comment is, boy, I try to avoid fusing to L5S1 whenever possible. PJK incidents clearly go up. It's a smaller operation when you can, and it's not an accident that I put reduced PJK in there twice because it's just such the bane of our existence. So do you need to have interbody support in biology? So if you're going to L5S1 for the previously mentioned reasons, do you have to do something to the interbody? I think the premise of this talk is, in quotation marks, yes, but there certainly is evidence out there that that you can obtain a fusion across the LS junction in long constructs with a combination of pelvic fixation and BMP. And that's not necessarily even there's a couple of studies, it doesn't necessarily even have to be high dose BMP. Daryl and his colleagues came up with a more moderate dose BMP and really showed reasonable healing. But in all these patients in both studies, all had pelvic fixation. And I think it could be argued that pelvic fixation and getting that rigidity is incrementally more important than interbody work, but we're going to talk about interbody work here today. So real quickly, spondies, low-grade spondies and DDD are certainly clear reasons why we might fuse L5S1, but again, outside the realm of this talk because they don't involve these bigger operations. So there's a new list now. Spinal imbalance is the main thing we're going to be talking about. Coronal imbalance, flat backs, correction of pelvic obliquity. Those are the things that we are almost mandated to go to L5S1 to address. So why in general do we talk about doing interbodies? the disc itself can be a pain source, as we know in degenerative disc disease, and in part sometimes isthmic spondyes. I don't think there's too much of an argument that we're adding surface area for the fusion. And then the question is, can we get better correction by being in the inner body? If it's done correctly, it should add some rigidity to your construct. If done incorrectly, it can, and with looseness there, can actually hurt that. But assuming we're all excellent at this, we can get a little more rigidity. So it can be an adjunct to adult deformity surgery. So if you're going to the pelvis with this imbalance that that Mike was alluding to, my standard go-to would be to do an L4 to S1 anterior. So I'm revealing my biases here early in the talk. And the thought behind that is that puts lordosis where it's most natural, enhances fusion rate at the areas of highest risk. And then I'll do the rest of my posterior-based osteotomies between L1 and L4. So one of the charges here is to discern which one's better, A-lifts, O-lifts, or T-lifts. I think for the purpose of L5-S1, we're really, A-lifts and O-lifts are basically equal. You don't want to come lateral to the vessels at L5-S1. And most of us would approach anteriorly L5-S1 through a retroperitoneal approach. You can go transperitoneal. I certainly have occasion to do so. If it's a revision operation, or particularly if there's previous radiation to the pelvis. But in doing so, you might get a little higher incidence of retroejaculation. Those nerves are right kind of on the back of the peritoneum. So I prefer to go retroperitoneally, which almost by descriptive definition makes my A-lift equal to an O-lift. But again, we're going to talk mainly about these two, A-lifts and T-lifts. So what's the difference? If you look at just these two, we do have much to go to in the literature. I stuck to some meta-analysis just for larger patient groups. This is almost 1,240 cases. A-lifts gave a higher disc space height. You might, this is somewhat intuitive, these results, but they do, and again, they make sense. So a little higher disc space height, a little better lordosis, segmental and overall lumbar, but with longer hospital stays and a higher incidence, obviously, of vascular injuries. T-lifts did have a slightly higher rate of dural tears, but they had similar fusion rates and similar clinical outcome. This is another study, a little bit smaller. Looked a little more specifically at local lordosis, which is a little more of a topic nowadays. I look forward to hearing Daryl's comments on this. A-lift had a little better lower lordosis versus the T-lift, but again, similar fusion rates and clinical outcome. This is one argument, and I understand what Mike was saying, we might see a counter later, but the idea of if you get PJK, can you correlate that to where your correction is being done as you reestablish lumbar lordosis? So this is a propensity match group, meaning they were matched for preoperative spinal balance and similar correction of overall lumbar lordosis. But when you look back on it, those patients that had PJK had smaller lordotic changes at their lowest levels, meaning there appears to potentially be a benefit from getting that lumbar lordosis correction in the lower lumbar spine in attempts to avoid PJK. And this looks at hardware failure and pseudoarthrosis and presumed pseudoarthrosis rates, T-lifts versus A-lifts and long constructs. I do think it's a little more technically challenging to get good surface preparation in the T-lifts than the A-lifts. And this bore out as having higher rod failures, particularly lower into the construct down by L5-S1 when you did a T-lift versus an A-lift. So this compares local correction, A-lifts versus T-lifts. These are pretty low numbers, frankly, for correction. But what we're seeing nowadays, not included in that study's meta-analysis, are hyperlordotic cages, which do appear to give better local correction. On the counter argument, what about expandable cages and T-lifts? I did a brief PubMed search looking for expandable T-lift cages in adult deformity and didn't come up with much, but this was a study that looked at T-lifts expandable versus standard and not a profound difference between the two. So the authors questioned the expense of the expandable cages. So that story is yet to be written. So So you can see my biases there that come through in papers I chose. I do like to present that way. That I do have a slight nod in adult deformity patients to the ALIF approach. But what about the role of pelvic fixation? Now we've got a new list. I would add, because you're not mandated to put pelvic fixation in short constructs to be sure, but when you're doing spinal imbalance cases that we were talking about, coronal imbalance, flatbacks, and pelvic obliquity, there doesn't seem to be a bit of a mandate, but there's got to be some guidelines for that. If you've had a previous fusion and you're revising a junctional kyphotic problem and your previous fusion's 4-to-1, I think that's a little overkill to put pelvic fixation in that. But if you have a problem at the L5-S1 level, be it a previous pseudoarthrosis, or you're decompressing below a previous fusion, or just linking a previous long fusion to the sacrum, or a de novo large case to the sacrum, pelvic fixation is usually a go-to. So most of us, anyone doing this is well aware of McCord's pivot point described, almost 3 decades ago. It's right at the posterior junction of L5-S1, posterior aspect of the disc, that is. And the argument for the biomechanical point of that pivot point is that if you're putting screws in distal to it, you really want to get the length of that screw well past that pivot point, meaning if you put short screws in, the failure mode is simply to pull those screws right out of the hole. Whereas if it goes beyond the pivot point, as you can see in that upper right picture, if this were to fail inflection, those screws would have to plow right through the best part of the bone of the ilium, namely the posterior column. And if it's ahead of that pivot point, that is a much more challenging mode of failure. So you're going to have a higher incidence of success. Briefly, how do you put these things in? What are you aiming for? How long should the screw be? The PSIS, and there are other techniques. We're all aware of the S2 Ayler screws as well. But the idea, again, is to get a long screw in, minimum of 80 millimeters in adult male, 70 in female. The majority of cases in my hands are usually about a 7.5 by 100 or an 8.5 by 100. And I generally am going to be aiming towards the ASIS, which you're seeing in path B on that picture. Further on the technique, you do want to avoid proudness of these things. That's the advantage of the S2 AIs. They are in line with your construct. I don't like putting a screw across the SI joint in my patients, so the majority of the time I still am doing these PSIS starting points, but I do rongeur them pretty aggressively to recess the screw. Use a pedicle finder. If there's a lot of pelvic tilt, I don't like using fluoro, etc. I will just kind of dissect out the outer table and palpate the notch myself and put them in a direct vision is my preferred approach. But critical, do not leave that room until you've got x-rays confirming that those screw tips are not in the acetabulum. So what is the role? Here we go. So long fusion to the sacrum in a primary case, iliac fixation in that. Linking a previous fusion. There's a case with a thoracic curve previously fused. I did a lot of anterior support here. I did a 4-level anterior to bridge the entire column anteriorly, and I don't like leaving a empty single 1 or 2 disc spaces in a long construct that I'm extending, so I will often do it this way. A high-grade spondy, you don't think about this much. Here's a nice post-op picture where we got this thing nicely reduced. I was pretty happy about it, ready to go home, get my discharge films, and you can see the obvious failure here, cut out of L5 on one side, S1 on the other, and took the patient back and did an anterior posterior reconstruction, was obligated to go up to L4, which is a bit of a bummer, but was able to recoup, and I locked it in with iliac screws. Complications, we're all aware of the windshield wiper sign. That's not necessarily a complication. That might be just a fact of ongoing motion in the setting of a solid fusion because that screw is spanning the SI joint. It's fairly low risk to go back and take these screws out after their job is done. Don't like doing that before a year, and I actually like to try to push people out to 2 years. As you're putting them in, you can get injury to the sciatic notch. Watch acetabular violation. That's a non-starter. hardware prominence can be an issue, but planning ahead can help you. So in summary, iliac fixation incrementally will provide increased rigidity compared to an ALIF. So if you really want to get as strong a construct as you can, you do want to use pelvic fixation. And the interbody in my hands does have a role, clearly. I do favor the anterior versus the T-lift, but I think both are viable when you look at the clinical and fusion results. So with that, I will move on, Jeff.
Thank you, Cliff. Great talk. Great talk. So again, submit your questions to the Q&A. Some of them have been answered in the chat, but we'll pick some of these up for answer later. Next will be Daryl Brodke from Utah talking about PJK and PJF. Daryl.
Thank you, Jeff. And thank you, Jason. It's an honor to talk to you all, and good evening, everyone. So I'm going to talk about proximal junctional failure, prevention and management. Those are my disclosures, and this is what I'll be going through. Kind of go through the definition of PJK and PJF. Then we'll talk about some risk factors, then management and prevention strategies. So it's remarkable that this has really only been in our lexicon for the last 15 or so years. The definition of proximal junctional kyphosis came into being with this publication in 2005 with a change of 10 degrees from preoperative to postoperative as measured from the inferior end plate of the upper instrumented vertebrae to the superior end plate of UIV +2. And this is the paper out of the WashU group. And they looked at 81 consecutive patients and identified this progressive change as a potential problem and identified in who they found it in. And they saw it about 25% of the time and saw no difference in the SRS scores and outcomes of the patients, but had some concern about it. And about 3 years later, they followed up with this paper that Kim first authored, now with 161 patients, and started to identify some real risk factors which have followed us all the way through to today. The incidence is a little higher at close to 40%, and they noted that timing for most of these occurred quite early, within the first 8 weeks. Again, they didn't really notice a difference in outcome scores for the majority of these patients, but noted that an older age group and fusions to the pelvis in particular were risk factors. Yagi and Boachi and the group out of New York really started to focus on the kinds of proximal junctional kyphosis and noted type 1, which was a ligamentous kyphosis, and just a progressive, longer, this took a little longer to form and often didn't have symptoms compared to a symptomatic type 2, which was a fracture or an implant failure, type 3. And those particular proximal junctional kyphoses were much more problematic. They also looked at a grading scheme where it was mild if it was 10 to 14 degrees of kyphosis, moderate at 15 to 19 degrees, severe if it's greater than 20 degrees. Well, from this 2011 paper, we really start to see the definition of proximal junctional failure, which is the grade 2s and 3s, which with grading B and C. So the more severe proximal junctional kyphoses really are what we're talking about when we talk about proximal junctional failure. The actual definition came out with this paper in 2013, and the International Spine Study Group focused on proximal junctional failure because the revision rate is so much higher in this group, so that where proximal junctional kyphosis often didn't change SRS scores, often progressed slowly over time, particularly that ligamentous group, that type 1 group. The proximal junctional failure group had a much higher rate of revisions. And it is, by definition, a proximal junctional kyphosis of greater than 15 degrees, proximal junctional fracture, instrument failure, or need for revision. Now, in their initial group of patients, they only found this about 6% of the time, much lower incidence than was seen for the proximal junctional kyphosis group overall. However, as we start to refine the patients that we're looking at, we see this much more commonly. And we've really seen this a lot over the last 10 years in all of our groups. This is our group out of Utah. We looked at older patients, many of them with sagittal imbalance as the reason for surgery. It was a retrospective study, so plagued with the issues around retrospective studies. 165 patients, all of them over age 55. We can see they span 55 to 84, multi-level fusions, obviously. And the incidence was quite high, particularly in those that we fused to the low thoracic spine, much higher actually than those we fused into the upper thoracic spine. And kind of an intermediate group that we fused the upper instrument of vertebrae was the lumbar spine. This theme of fusing up to the low thoracic spine, you'll see over and over again as I start to present some of this. Interestingly, back to the WashU group, they looked at the difference between the various levels in the low thoracic or thoracolumbar junction, we'll say, because the dogma had been don't stop at T12 or L1, so either go up or stay short. That had been a dogma for years in the deformity world. And what they found was didn't really matter. The incidence of proximal junctional kyphosis was about 50-ish% at T9, T10 or T11, T12, a little bit lower at L1, L2, but the revision weights were interestingly quite similar across all three groups. So the level that one stopped at all by itself did not determine failure rate. We did start to look at things that did help predict failure rate. And we looked at a multivariate regression analysis and noted that two things really stood out. When we changed the lumbar lordosis significantly, more than 30 degrees, so we're dealing with a sagittal imbalanced patient, the incidence is much higher. The odds ratio is 7 times greater than the average deformity patient, and particularly much higher than coronal imbalance patients that we're operating on. The other is looking at the post-operative proximal junctional angle, the angle from the inferior plate of the upper instrument of vertebrae to above. And when that is greater than 5 degrees, the rate of proximal junctional failure goes up. So again, in different cohort, we found that fusing to the low thoracic spine had the highest risk, and those in which we changed the sagittal vertical axis by more than 5 centimeters had a much higher risk of proximal junctional failure. Finally, we looked at our revision rates for all of our deformity patients. This is 216 patients now during the time period that this study went on. And our revision rates at final follow-up were fairly equal in those that we stopped in the lower thoracic spine versus the upper thoracic spine. But the reason for revision was much different. The reason for revision in low thoracic spine was proximal junctional failures we've talked about. The reason for revision in the upper thoracic spine was pseudoarthrosis. So really a mechanical problem that we have yet to fully solve when we stop in the low thoracic spine versus a biologic problem, which Wellington's going to talk about shortly, that he's solved for us in the upper thoracic spine. So we'll keep that in mind. I want to run through a couple of cases and then we'll talk about some management and then prevention issues. This is a 74-year-old woman with L1-2 and L4-5 non-unions, severe low back pain, neurogenic claudication, and we can see that she's collapsed above and below and is able to hold herself at least in a standard lateral 36-inch film, but actually walks much more bent forward than this. She's got a pelvic retroversion that's quite significant. So we were quite happy with how this ended up. This is her post-operative film on post-op day 1, and this looks good. She's well balanced. She's standing straight. She's feeling great. Our proximal junctional angle is 8 degrees. It's a little concerning. You know, our upper instrument of vertebrae, the screws are behind S1, another little bit of a concerning issue that's very hard to gauge when you're trying to figure out when they're lying prone on a table if that's how they'll stand. So 6 weeks later, this is how she looks with a proximal junctional angle of 37 degrees and 9 months. And she held on. She's feeling okay. She didn't want to have revision surgery. However, by 9 months, she was not feeling so good. So she now has a 53-degree kyphus at the upper end of that. And these are her post-operative films. And this is a common way that we'll fix these with an end-to-end connector as well as satellite rods to protect those, and then going up into the upper thoracic spine to manage the overall curve. It's another patient, 80-year-old woman with back pain, neurogenic claudication, otherwise healthy and was active, has Degen scoli, and was straightened out and decompressed and did well. and was pleased with her result initially. 2 years later, she had slowly progressive degenerative change and had difficulty standing straight up. She also had, subtle to see, she had an ossified disc here with associated spinal stenosis. In addition to, this is her, obviously she's lying supine here. This is a CT scan, sagittal recon, but she would kyphose more as she walked into and out of the clinic. And again, we were able to straighten this out through a Ponte osteotomies or Smith-Peet osteotomies across the kyphosis site, inline rod connectors offset by one level, as we can see here, and then satellite rods to protect those. So that was posterior osteotomy. This then is the last case I'll show, 62-year-old woman with progressive kyphosis above a lumbar multi-level fusion that required a PSO at L2 for realignment and was pleased with her ultimate result. So the techniques for management generally are to fuse at least a couple levels above, if not into the upper thoracic spine. One of the decision-making factors for the upper thoracic spine versus a few levels above where we've stopped has to do with where those few levels end and what the proximal junctional angle is at the level we're about to stop. And if that's greater than 5 degrees, we'll keep going up. If the thoracic spine has a significant kyphotic deformity, we consider including it at the time of revision. We remove loose screws and replace with larger diameter if we can, or skip those levels. Decompress is needed for spinal cord compression. We try to shorten around the kyphosis with Smith-Peet osteotomies or sometimes a PSO if it's required, though it isn't usually required. We use inline rod connectors and satellite rods to increase strength. So lastly, I'll talk about techniques to decrease the risk of proximal junctional failure. What seems to help? Well, this is a controversial area, actually. We have not really solved this problem. I'll give you a few tips that I found that I use and that are in the literature, and we have a lot more work to do, I think, as a group. Don't end the construct in lordosis is a big one, or behind the sacrum if we can help it. Begin or continue the thoracic kyphosis at the top levels. Choose an upper instrument of vertebrae that preoperatively has a proximal junctional angle of less than 5 degrees. That's a pretty consistent finding for increased risk of PJF. Do not fully correct to young adult normal sagittal balance in the elderly. Normal is forward, and just a sort of a rough approximation is to add about 1 centimeter per decade. So if 5 centimeters is the upper limit of normal in the young adult, patient's 60, make that 6 centimeters. If a patient is 70, make that 7 centimeters. Patient is 80, make that 8 centimeters. Avoid overly rigid constructs. We've really rethought the whole use of chrome cobalt rods and now almost never use them. Stay very low in the lumbar spine, even when possible. This is a good study by the International Spine Study Group's multi-spanner prospective data collected study on 625 patients. And they really looked at two things. What they called surgical implant prophylaxis, which I'll talk about in a second, and then the avoidance of alignment overcorrection. Alignment overcorrection is key to this. So I'll just sort of dispense with that and talk about this other, but make sure you're not overcorrecting to a normal sagittal balance in a 70-year-old. The highest incidence of patients who had proximal junctional failure were overcorrected and did not receive implant prophylaxis, which they looked at, which were hooks, a tether, or cement. And then they looked at the performance of each of these, and you can see on the right, this table, that hooks, which is the second from the right, had the lowest overall incidence. This is hooks at the top level to soften the transition, had the lowest overall level of proximal junctional failure, but it's the tether at UIV +1 or +2 that had the lowest overall revision rate. And it's that tether with a Merceline tape through, around, and through the level above the upper instrument of vertebrae. And then some people tie to the rods, or some people tie to a cross link. I've been doing this lately. That seems to show pretty good outcomes in most of the studies that talk about it. Last paper I'll talk about is systematic review of treatment strategies to prevent proximal junctional complications. And they looked at those same three things. Cement augmentation seems to have pretty good outcomes in retrospective studies. I've certainly revised patients for proximal junctional failure through cement, so it's not universally helpful. Tension band augmentation with Merceline tape seems to have pretty good outcomes in a number of studies, as well as teriparatide. The data is young, but seems to be gaining in support. So hooks of the proximal end, cemented UIV or UIV +1 and spinous process stabling with Merceline tape seem to maybe help. Maybe I'll underscore. There were some other ideas out there, and there'll be more in the future. Dynamic stabilization at the top of a construct, MIS at the top of the construct, or two that we're looking at, but may have some merit, but so far haven't borne out. And with that, I'll stop. I want to thank you all for joining us this evening.
Thanks, Daryl. Excellent talk. You crammed a lot in your allocated time on this very difficult and complex topic. Before I introduce the last speaker, I want to let you know that we will go ahead probably past the hour, about 15 to 20 minutes for those that want to stay on for live question and answer. I don't know if all the panelists can stay, but we'll do the best we can. Some of the questions are going to be answered in the chat or in the Q&A session itself. For our last speaker now, let me introduce Wellington Su from Northwestern University. He's going to give us the definitive answer on biologics in adult spinal deformity. Wellington.
Thank you so much, Jeff, and thank you, Jason, for the opportunity to speak. I'm going to try to keep this short so we can keep on time and have the discussion for later. These are my disclosures. When we talk about spine fusion, clearly when we are talking about adult spinal deformity, it's a lot different than a one-level ACDF, one-level lumbar fusion. These patients are sick. They need more from us than what we can give for our garden variety fusions. And patient-specific considerations are important. If you look at all these comorbidities that can affect fusion, many of our patients have one or additional numbers that can affect the biologic environment. And then furthermore, if you look at the spine structure, high-grade spondies, if you have a coronal and sagittal deformity, a multi-level problem, now you're demanding more. What we're thinking about for a one-level ACDF doesn't really apply here. So we're thinking about potent biologics that allow us to fuse and hopefully save this patient another operation. Because we know now that there's a cost. There's a cost of pseudoarthrosis. And if you look here, readmission rates, 24% for all adults, spinal deformity patients. A bulk of this is for individuals who have pseudoarthrosis, who break their rods. All the techniques that you just heard Dr. Broggi talk about are designed to try to prevent this. If you have a biologic that is in that environment, then hopefully you're not relying on 4, 5, 6 rods in that area in order to achieve a good outcome. If you look at what's on your shelf in the hospital, it's dizzying to think about all the options that you have available. But as surgeons, it's really important for us to compartmentalize and think about these options into different categories, and then look at those categories and then assess whether or not they're appropriate for adult spinal deformity patients or whether they're not. Things we have to think about: safety, efficacy, and cost. Unfortunately, the most efficacious biologics that we have seem to have the most concerns for safety and also the highest cost. So trying to find that happy medium, I think, will be the goals when we look at future research and where biologics is going. The U.S. bone graft market, if you just look historically, has changed significantly. A decade ago, half of us were using growth factors for fusions. This decreased by 50% in 2015 with concerns of complication. And in today's world, we have a happy medium. But this is going to change. This is going to change with new products that are coming about, with new studies that are coming about. And since there is very little data with a lot of the products that we use, any little data that we have or any additional data that we have can certainly move the needle. Looking at these categories, just some take-home points. Allograft doesn't work when used alone. It is certainly the most economical bone graft extender, and there are many of my partners who at Northwestern for T10 to pelvises use allograft in an appropriate patient who may not need a bone graft substitute like BMP. There's little data because there's just not a lot of incentive for companies to perform randomized controlled trials for this particular category. There's a little difference in price and performance for these products in this category, but there are premium products in this space, such as OsteoAmp. There are different products that work in different ways that do demand a higher price point because they work better. If you look at DBM, there's certainly variability dependent on donor and carrier. There's only data as a bone graft extender, not a substitute. Fiber products are better than granule products. And because many companies have 100% human tissue products available, your hospital should demand this. It makes sense that you want 100% human tissue product instead of having 85% carrier, but you also have to be aware of private labeling. These products, Allofuse, Propel, Stimulblast, they're the same product. And if your hospital pays a different amount for each of them, there's really no reason because they're the same product. Now, DBM doesn't necessarily apply right now as a bone graft substitute, but I think the DBM has a number of qualities that are important to watch for. Many of my collaborators on the basic science side had devised ways to use DBM as an ink, as a 3D printed mechanism. And if you can 3D print something, then you can take the variability out of many of the products in this category that we're looking for in the future, and hopefully improving biomechanical properties as well. Cell-based matrices comprise a significant amount of the market in terms of spine fusion, and there are surgeons all over the world using it for adult spinal deformity. The source of cells can vary between adipose and bone marrow. The processing method really makes me think of this category as a dirty DBM, meaning that it's DBM plus additional factors like growth factors and cells. One needs to think about, though, is what the mechanism of action is. And so if you use a cell-based matrix, you really have to subscribe to how it works. And I'll demonstrate this in a sec. If you use a mesenchymal stem cell product, you are basically hedging your bets, meaning that the stem cell can turn into the osteoblast or the osteoprogenitor cell that eventually leads to bone healing. A number of products on the market that are listed here are in this category. So you're really looking for this product to create either a differentiation effect into that osteoblast progenitor, or you could just say that these MSCs are providing a supportive environment. A trophic effect does not need to necessarily turn into the osteoblast progenitor, but just secrete the growth factors that can help increase healing. On the flip side, if you use something like Vivigen, this is a primary osteoblast product. So if you're using it, you're really counting on each cell that you will deliver to the patient to differentiate into an osteoprogenitor cell and then lead to the bone healing characteristics that you'll eventually want. There is no trophic effect for something like Vivigen. So one needs to think about it. It's much more difficult for that to work through a differentiation effect than a trophic effect, as many cell biologists have published. But if you think about how decisions with CBMs are made, there's just very little data. And if you think about how much it costs, there are opposing forces and trends with this category. There's little data, there's high cost, there's FDA scrutiny, there are insurance rejections that are increasing over the past couple of years. And there's been an industry focus on this category, in my opinion. So although they exist and deserve mention, I certainly don't think about the promise of this category as significant as others, such as synthetics. Synthetic carriers are comprised of a number of different materials, but the key for this product category is that they're more flexible, they're less variable, and they have better biomechanical properties. And the reason is because they can be manufactured in a way that's more standardized than some of the other product categories that we have. Historically, it's only a bone graft extender. There are no studies that show that you should be using this as a substitute. There is a favorable cost profile, and many of the studies historically have shown good fusion rates. So it's not that there's no data in this category. You could argue that this data is not strong data, and I would agree with that as well, but there is data. But if you look at the potential for this type of category, one need not look further than a sci-fi movie, that's animated to say that if you construct a building block, and the building block then is constructed amongst themselves, then you can create structures that can then help build and lead to healing. And so the adjunct for this in biologics would be the peptide amphiphile, which I've had a lot of experience with the Samuel Stoop lab at Northwestern. And we published a number of studies on how this type of nanofiber solution, this creation can allow us and allow surgeons to deliver a synthetic in a gel. It can be absorbed in a porous carrier, or we can create a paste or putty. So the handling properties can be adjusted to deliver in a certain environment, whether it's adult spinal deformity or your garden variety fusion. So this synthetic category allows us, for many different manufacturing methods, the use of different biomaterials, and in my opinion, represents promise for the future. And the final topic I'll talk about is BMP. So all the folks on this call do not need a lecture on how well BMP works from a fusion ray perspective, whether it's an anterior lumbar interbody fusion, posterior lateral, T-lift, even lateral. All the studies show that it heals very well. But on the flip side, we have to be concerned about complications, which have been related to the dosage that we've used in the past. I would say that we see a lot less complications now than we used to. But in terms of deformity, this is the only product that has been shown to be cost effective. And there's many studies that have been shown that if you use BMP, you reduce reoperation rate compared to a comparative biologic, which makes sense because it's a lot more potent, a lot more osteoinductive. I would say that there's no reason to use more than one small kit per level. And I would almost go to say that you really shouldn't be using, or don't need to use, one large kit per patient. And that applies for anybody who's T10 to the pelvis, T4 to the pelvis, what have you. I think you can focus the really potent biologic in the areas where you need your fusion. And using much more than this really opens up the possibility for increased complications, and there may not be a huge benefit if you're already using a large kit. I would advise folks who are using adult spinal deformity for BMP to be posterolateral only, to avoid posterior interbody use, since again, this opens up a whole slew of complications that you would not have posterolaterally, and also to use with master graft, because this is not only a good adjunct as a bone graft bulking agent, but also can reduce the extravasation of this protein in areas that you don't want it to be. So to conclude, your choice of biologics for adult spinal deformity really depends on what the patient looks like, what your procedure looks like, what the evidence is, what the cost is to you in the hospital, as well as the handling properties. The data for existing biologics is variable. You want to know your categories, because I think all of the categories have a role in the type of deformity that you're treating in your deformity practice, because I've seen them all used and I've seen them all work. Use of BMP in deformity makes sense, but other extenders can also be effective in the presence of autograft. So whether you have autograft or you don't have autograft, I think these can be used to make it more cost effective as well. Thank you very much.
Thank you, Wellington. Excellent presentation, and thanks to all the presenters. Many of the questions have been answered in the quick Q&A window themselves. We'll have a chance to kind of touch on some of those over the next 12 minutes or so. One of the questions was asked by Jonathan Sombrano on using an alias, had to do with the age-related factors relating to targeted goals for spinal deformity correction. And I think it was addressed to Mike and also to Dom. Do you care to comment further on this, particularly with regards to the GAP score and the work by René Lafoge and others? Please go on. Mike, you're muted.
God, do you think I was in 2019 or something? I should know that by now. So, the GAP score, I haven't really used it I haven't integrated in my practice, I'll be very honest with you. But when I look at it, it does compare, like, your pelvic tilt and all the other parameters to an ideal parameter for that age. And they're using a 60, greater than 60 and less than 60, which probably is within, reason, within a few degrees as far as comparing what the age-related goals would be. So I think that may be something. Daryl may want to comment on this. When we looked at the lordosis index, that maybe that's not as much as we think it would be, meaning the lordosis and where we get the lordosis. I don't know. I don't think, other than, the pelvic incidence and their pelvic tilt, I think, which is really age related as well. I think that's probably what most of us use. I don't know if Daryl wants to comment on that.
Yeah, I'll just quickly, because we looked up, a lot of our patients, again, plagued by a retrospective study with a change in how we did cases over a period of 10 years. But we tried to figure out if this low lumbar lordosis or lumbar lordosis index was independently of value, because we focus a lot on that, when have in the last few years really focused on trying to build our low lumbar lordosis as we construct our deformity reconstruction and sagittal imbalance. And we weren't able to show it. I think, as you showed, or somebody did, ISSG has been able to show it. Maybe Cliff was able to show that paper, but you know, we just didn't show it as an independent risk factor for PJF. That said, I still think there are a lot of benefits to focusing on low lumbar lordosis as you reconstruct the sagittal balance. And so it hasn't slowed me down. It's just not all by itself a factor in PJF.
Great. Alpesh Patel asked a great question about how to essentially get all the stakeholders in the healthcare team to be on board about preoperative optimization and management. And I think Mike wanted to discuss this further. Mike, your comments?
Yeah, you know, I think if we look at our joint colleagues, at least in orthopedics, you know, they've really done a good job of trying to look at the whole process, pre-op all the way to, you know, even the post-acute care setting. And we've had to look at this. We have a big group of Medicare Advantage, which is a full risk population that we take care of. So every part of those steps the patient goes through, we're responsible for, essentially. So we are now trying to do the things that our joint surgeons have done and make sure that we have every aspect of that controlled, meaning that when they go to the nursing facility, we have one of our people, a PA there, assessing them. When they go home the next day, somebody's there to look at them and see what they need. And that's the only way that I think we can control the whole process. I mean, I think a lot of us are tired of the fragmented system. We send a patient, they go to sniff, and they come back with an infection, they were laying in their own feces, stuff like that. And I agree with Alpesh, but it's really hard unless you're in a system that's, you know, a contained system. Otherwise, it's really hard, really difficult.
A question that I had for the panel is S2AI versus traditional iliac screws. We heard the talk about the pivot point, also known as the instantaneous axis of rotation, I believe, in McCord's paper on that. But I think you can achieve the same goals with that. Have most of you, are you still doing the traditional iliac screws when you do pelvic fixation, or have you moved to S2AI? For the most part, I've moved to S2AI, and I think they're just as effective and less symptomatic, and also easier to put in, by the way, with MIS technique.
So I would say that we probably do some of both, and it kind of depends where the posterior sphenoiliac spine, the kind of that medial wall of the PSIS, comes in relation to our S1 pedicle screws. And if the PSIS medial wall is pretty medial, then we'll just bump out to putting in a low iliac bolt. Now, we don't put them in the same way that we did when we first started putting them in. We put them in very low and deep. So they're coming into the ilium through the medial wall, deep and medial, and then in the same path that Cliff showed. If the PSIS is sort of in standard place, somewhat lateral to that, we tend to use an S2 iliac bolt unless the S2 lamina or posterior cortex is thinned out and doesn't really allow us to follow a good path through the sacrum, and then we'll kind of start low again in the medial cortex of the ilium and then use an offset. That's sort of option 3. So we have kind of 3 options for how we put them in. And I would say mostly S2 iliac bolts is probably number 1, followed by iliac bolts, medial and low, followed by an offset connector.
Great.
I don't know what other guys do, but
Any other thoughts?
My bias is to put them as I described, but I will use the S2AI in a very thin patient or even a younger patient. Biomechanically, I think you're still well past McCord's point, and you get the addition of another couple of cortices. So at the cost of going direct across the joint. So it's frankly, to me, it's 6 one, half dozen the other.
Great. So Daryl, a question for you. That was an excellent talk, and you crammed a lot into the time that you took to give this presentation. There's a lot to cram in for 10 minutes or a little bit more. What do you think the leading cause of PJK, PJF is? Is it overcorrection based on age, or do you think it's too multifactorial?
Well, the leading cause changes as you keep correcting what you think is the leading cause, right? So I think the leading
right.
Yeah, the leading cause is doing an operation.
yeah, it used to
Leading
be
cause is spine surgery,
Yeah.
adult deformity surgery.
I think doing sagittal imbalance surgery for sagittal imbalance in osteoporotic people is a leading cause of proximal junctional failure, and it's a risk that's probably greater than 35% in that group, maybe as high as 40+%. A number of things that I hit, we don't do anymore. You know, we don't end our constructs in lordosis and then let them fall apart over the top. And yet we still see proximal junctional failure. We just don't see that as the cause.
One of the things that Steve Glassman discussed is that we tend to do these patients in a non-physiologic position. They're maximally extended on a Jackson table with bolsters or some other type of spine table. And naturally, they're going to have a little bit of kyphosis there. And if we correct them as they lie at the proximal junction, I think that they're definitely overcorrected at the upper end vertebra. Do you agree with that, Mike and Cliff and Daryl and the rest of the panel, Dom and Wellington?
Well, I like the idea of getting correction distally. So the whole idea of the soft landing, I've actually started putting in a hook on one side and a single screw on the other, or even a single screw to top it off. I can't say I have any lower incidence, but I keep, as Daryl said, you keep playing with different things and the next problem pops up. But it does make sense to me to have those last three upper levels to be truly without any corrective forces on it as
Right.
the patient lays there.
Yeah, so I've really tried to build kyphosis into the top of my constructs. And to the extent that I'll even go a level higher if I haven't sort of done that yet, or if I'm worried that I can't do that at whatever level I've chosen to make my upper instrumental vertebrae, I'll go one more if I can, in order to distract and start to create kyphosis. And I'll tell you, I've used, this is very incidental level 5 evidence, so take it for what you paid for it. But I do use now Merceline tape around the UIB +1 spinous process and then tie it around a crosslink, very much like Chris Ames has taught. And I've been doing that for a while, and it feels like my PJF rate is lower than it was. It may be that I've done a lot of other things too, and so it's hard to say.
Daryl, do you wrap it or do you drill it through?
I use a towel clip and go through, around, and then back through. So I'm kind of wrapping and grabbing it, and then bring both ends down.
You know, we've been bending into kyphosis for the last, Daryl and I from
Yeah,
Daryl,
you were here
10 years, right?
Yeah.
And we didn't change, I don't know if we really changed our PJF or not, but I do think hooks has made a big difference in my practice.
Except for all the hooks that I revised.
I don't think I used hooks back then.
So are these sublaminar
I've gone through
hooks?
this series of hooks and no hooks and then hooks and then no hooks, and I keep revising them.
I think
The nice thing about hooks, particularly as you get up into T3 or T4, the failure mechanism is not nearly as catastrophic. And those PJKs or really PJFs up around T4 really can be a disaster. So at least you're not avulsing the body and just jerking everything out. So,
Right.
So are you using sublaminar hooks or transverse process hooks at the top?
I generally use TPs. I have
Right.
not gone to the sublaminar ones, Jeff, but frankly, I do have a thought that might be a stronger, softer landing, if you will. And the other one that I toyed with, and I haven't done yet, I'd be interested to see if anyone on the panel has, is to use the rods that taper from the 6.0 rod down to a 3.5 rod. I've not done that, but it's very intriguing to me to putz with that one as well.
Mm. Yeah,
I'm
that's
thinking-
kind of in that last section that I talked about where people are talking about trying new things. But that Merceline tape sort of soft landing concept in the upper thoracic spine is easier than hooks are. It's easy to hook up because you see the T2 spinous process as you're, right above where you're putting your T3 pedicle screws in. So it's right there. It's quite a bit easier than the struggle that routinely we go through getting hooks at the top.
Right. All right. Well, I think we're 20 minutes past time. I want to thank the panel and thank my co-chair, Jason Savage, for assembling this. We please stay tuned for next Tuesday. We're going to have case presentations, and I think it's going to be a fantastic session to wrap up the 2020 instructional course held now January of 2021. Thank you all very much, and good night.
Thank you, guys.
Thanks, Jason. See you guys.
Yeah.